Good morning, ladies and gentlemen. The topic of my today's lecture is dermatosis due to mechanical injury to the skin. And I am Professor Asher Ahmed Mashood. And if you have not joined my channel, please subscribe to my channel. So let's proceed into today's lecture. Introduction. The skin is constantly subjected to both internal and external mechanical forces that are likely to be important in the maintenance of structural integrity of the skin. Mechanical stretching of keratinocytes induces a hyperproliferative response via activation of extracellular signal-related kinases. So, the mechanical injury to skin is not that dangerous. Rather, these kind of injuries, they are important to maintain the structural integrity. And stretching of keratinocytes induces an hyperproliferative response. Healthy skin is well adapted to resist the adverse effects of friction, pressure, contusion, laceration, suction, and vibration. All are the different mechanical forces. The clinical consequences of injury will depend on the characteristics of the noxious stimuli, such as its intensity and duration and factors related to the skin. Isomorphic or Koebner response. The isomorphic response is the development of lesions in previously normal skin that has been subjected to trauma. The response should be reproducible and not limited to one type of trauma. So these are the prerequisite of the Koebner response. It is little different from the isotopic response, in which dermatoses occur at the site of previous healed or unrelated dermatosis. So the Koebner response is the development of dermatosis at the site of trauma, which should be reproducible every time the trauma develops, and the trauma should not be of only one type. While the isotopic response is development of dermatosis at the previous healed site. Maybe the healed site is due to some other dermatosis. Pseudo-Koebner phenomena is the term which is used when dermatosis results from spread of an infective agent. For example, molluscum contagiosum or wart. This is a pseudo-Koebner. And reverse Koebner is the trauma. Due to trauma, the lesions start resolving. That is resolution of lesion following a trauma. So if warts or molluscum occur at the site of trauma, it is called as the pseudo-Koebner, and it is not a true Koebner. And if a lesion gets healed after trauma, it is reverse Koebner. Pathophysiology. Many forms of physical trauma that include friction, pressure, incision, and laceration, skin grafting, bites, vaccination skin tests, burns, freezing, and ultraviolet injury and ionizing radiation have all been implicated in this phenomenon. Pathogenesis. It seems that epidermis and dermis both contribute, but the epidermal damage is probably the critical event. There is increased influx of CD4 lymphocytes and local production of cytokines and adhesion molecules which contribute to development of a new lesion. Clinical features. In psoriasis, the Koebner response occur in about 20% of the patients. The latency to develop the response is 10 to 14 days. And Koebner response is more likely to develop when the disease is active. The Koebner response is also seen commonly in lichen planus and in vitiligo. And there is a list of other diseases in which this phenomena is demonstrated. And this disease include various cutaneous cancers, the Darrier disease, erythema multiforme, granuloma annulare, Hailey-Hailey disease, leukemia cutis, lichen sclerosus, lupus erythematosus, scleroderma, multicentric reticulohistiocytosis, necrobiasis lipoidica, pemphigus foliaceus, perforating collagenoses and folliculitis, mixed edema, pretibial, vasculitis, sweets, and xanthomas. So you just must remember that there are three common diseases, that is psoriasis, lichen planus, and vitiligo, and list of very uncommon conditions whose one or two case reports are in the literature that demonstrate the Koebner phenomenon. It's controversial whether it's appropriate to use the term Koebner phenomena for the pustular response to injury in Behçet's disease and pyoderma gangrenosum. This is also known as pathergy. Sarcoidosis is also known to appear in a scar, which is called as the scar sarcoid, and in some tattoos. However, it's not clear whether it's a true Koebner phenomena response or there can be delay of years between the tattoo and development of sarcoidosis. Utilization of the mechanical stimuli to facilitate the accurate diagnosis of the mechanobullous diseases. Simple friction trauma, such as caused by twisting or rubbing tip or twisting with a rubber tip pencil on the skin, is called as the Nikolsky sign and may be used to make a diagnosis of pemphigus vulgaris or toxic epidermal necrolysis. The pustular reaction to skin puncture, which is called as pathergy, is seen in Behçet's and pyoderma gangrenosum active states. Suction blister is evoked in bullous disorders, and suction also induces fatigue in scurvy. Firm stroking of the skin results in purpura in systemic amyloidosis, and stroking of skin is used to demonstrate dermographism. Applying standard amount of pressure to the skin as a part of dermatographometer is used to diagnose the delayed pressure urticarias. Effect of friction. Excessive friction force will cause an injury that can be acute, occurring in seconds or minutes, or chronic as a result of repeated and lesser degree of friction. The response of the skin will depend on the magnitude and duration of the frictional force and properties of the skin itself. Abrasion and friction blisters are examples of acute frictional trauma, but blisters can only form if the stratum corneum is thick enough to form the roof of a blister. Friction blisters are therefore difficult to produce except on palm and soles, while similar kind of trauma on other part of skin will result in abrasion rather than a blister. The best defined clinical consequence of chronic frictional injury are the calluses and corns. But many other forms of dermatitis are perpetuated by friction. Physiological changes such as degree of hydration have a large effect. Very dry and wet skin a much lower frictional resistance than moderate hydration. So very dry and very wet skin is more prone to develop these frictional blisters. Skin surface lipids have relatively little effect. Age and sex, no significant effect on frictional properties of the skin, but body size is important. The forehead and behind the ear have highest dynamic coefficient of friction. Abdomen the lowest. Rough skin and atopic have lower coefficient of friction and are more prone to abrade. Then reaction to the chronic mechanical injury, the callosities, corn or calluses. The callosity is a plaque of hyperkeratosis caused by repeated friction or pressure. On the other hand, corn is localized, sharply demarcated callosity occurring over a bony prominence, usually on hand or foot, and is painful. Soft corn occur between the fifth and fourth toes. Various intrinsic abnormalities of foot predispose to callosities. These include bony prominences such as hallux valgus, and prominent condylar projections and malunion of fractures. They are more common in elderly, particularly those with high pressure exerted on the plantar skin and often made worse or even caused by unsuitable footwear. Epidemiology. Callus may form in all age groups. Both sexes are prone. An inherited disposition to callosities has been described with autosomal dominant inheritance. Pathophysiology. In some rheumatic disease, for example, rheumatoid arthritis, there are distinctive pattern of callosities form which can be predicted from the joint involved. The diabetic subjects, especially those with peripheral neuropathy, are prone to form the callus formation. Faulty foot mechanics, as told before, when there is toe deformity like claw toe, hammer toe, or the mallet toe, in the hindfoot varus or valgus position of the heel, will lead to abnormal load distribution and formation of callosities. Calluses on edge of weight-bearing areas of sole are often caused by shoes that are too loose to wear. On the dorsum of the foot, factors provoking callosities include the footwear, habit of sitting with foot tucked under the body. Soft corn is a typical corn that develops in the interdigital cleft of fourth and fifth tarsals when the condyles of metatarsal or phalanx against the base of phalanx is rubbed. On the hand and other sides, callosities develop as a result of repeated frictional injury, which is quite apparent from the history. Pathology. The callus. In the callus, there is epidermal hyperplasia, and the underlying dermis shows increased dermal collagen and fibrosis. There is an increased expression of adhesion molecules, desmosin, desmoglein 1, and desmoglein 3. Corn is a little different, that there is a thick parakeratotic plug, as you can see in the picture, in a cup-shaped depression of epidermis, usually with loss of granular layer. So this is a typical corn. Clinical features on the plantar surface. The most common sites of corns and callosities are over the metatarsal heads, as you can see here. Although the sides and arches of heel are also involved here. A callus is ill-defined area of waxy, often yellowish thickening, over which the dermatoglyphic markings are intact. So these are callosities. A corn is smaller, usually very painful, and have a glassy center. It's just like a cone plucked into the skin. Callus and corn interfere with mobility, can damage the deeper tissue, even causing ulceration. In autosomal dominant hereditary callosities, blisters occur at the periphery of the hyperkeratotic skin. This is distinct from epidermolysis bullosa, epidermolytic hyperkeratosis, and blistering associated with palmoplantar keratoderma. So, callosities on hand are most commonly a distinct occupational stigma for in many trades and professions. Areas of thickening most commonly occurring on palmar surface over the metacarpophalangeal joints. Unless they become fissured or infected, they should be considered as adaptation rather than a disability. Callosities develop as a result of biting or chewing or sides or knuckle of fingers. These are called as the gnowarts. It's also seen in bulimia nervosa as a result of repeated manual stimulation of gag reflex. A distinctive hyperkeratosis on side of thumb can occur with use of the cigarette lighter. Prayer nodules are a typical kind of callosity seen in the Muslims on the forehead due to repeated touching of the forehead on a rough surface or on a prayer stone. Such kind of callosities also occur on the knee, ankle, and dorsa of feet from the sitting position adopted while praying. The differential diagnosis of callosities is mainly con is mainly the plantar fault. The skin markings are not intact over the wart, and wart is painful on pinching while the con is painful on pressing. Other DDs include keratodermas, granuloma annulare, and knuckle pads. Management. The patient footwear and other orthoses, the gait, and the alignment of feet should be examined. Radiography may be helpful. Aim of treatment is to provide symptomatic relief, determine the source of abnormal mechanical stress, relieve the cause by conservative measures, and consider surgery if everything fails. Relief of symptoms caused by con or callus is achieved by careful and regular pairing. Initial procedure is often best done with a scalpel and subsequent treatment with some abrasive device. Soft con, the use of toe separator in a form of felt foam of silicone, provide relief, and salicylic acid in a form of an ointment help in removing the cons, and even in a form of powder under a salicylic acid dressing. The role of patient shoe in producing callosity should be carefully assessed, and appropriate corrective steps must be advised. Examples of metatarsal pads for local plantar calluses, customized shoe inlays can be moved from shoe to shoe. When conservative measures fail, surgical correction of toe and deformity is required. Simple debridement in combination with topical application of 1% cantharidin and 30% salicylic acid, 5% podophyllin have shown to treat calluses effectively. And there is 1.4% recurrence rate. Now we have reached to the friction blisters. These are the blisters that form in response to acute frictional force applied across the skin surface. It is mentioned before that in order to develop a blister, stratum corneum must be thick enough to form the roof of the blister and strong enough not to be rubbed away. And hence, these blisters are common on palm, soles, heel, and dorsum of the fingers. Frictional force and number of times an object moves across the skin determine the likelihood of the blister development. The incidence is more in populations where there's an increased mechanical trauma, particularly on acral skin like military and athletes. The blister usually form in the spinous layer just beneath the stratum granulosum. Patients with EB have a genetic susceptibility to frictional blister. Skin hydration and increased skin temperature may increase the risk of blistering. Clinical features, usually self-evident and seldom present a diagnostic problem because the patient knows very well how the friction blister has developed. The patient may seek advice when a bulla appear unexpectedly or under inappropriate circumstances. In addition to the blister formation, there may be other consequences of inciting trauma like callus formation and petechiae. Skin fragility can occasionally be a presenting feature of systemic amyloidosis. Blisters are also seen in patients comatose from neurological lesions or drug overdose. Bullous insect bite reaction and other bullous diseases are confused with friction blisters. Management. Preventive measures include use of antiperspirant, 20% aluminum chloride hexahydrate in anhydrous ethyl chloride used for 3 days, foot powders with aim of absorbing the moisture, certain type of synthetic insoles, absorb the frictional forces and reduce blistering. When blistering has developed drainage as to allow the roof to adhere to the base, and it would provide the relief of symptoms and optimize healing. If the blister has burst and roof torn away, the wound should be treated with non-adherent dressing and protective padding. Hydrocolloid dressing are used with success. Black heel or black palm, also known as the talon noir. This is the pigmentation of heel or palm secondary to extravasation of RBCs. The condition results from shear and stress rupture of papillary capillaries during violent sports, particularly when repeated jumping and sudden stopping or twisting of the heel occur, most commonly in a basketball. Similar circumstances explain the occurrence on the palm. Young adolescents may be more prone, in addition to the athletes and sports persons. Either sex can be affected. The patient may not recall the precise onset and therefore not relate the blue-black pigmentation to their own activities. However, a history of participation in sports or other traumatic exposure to the heel will often be elicited after a detailed interview. Presentation is with closely aggregated group of bluish-black specks occurring suddenly on the back or side of the heel. The lesions resemble a tattoo or melanoma, which is the most important differential. Dermoscopy visualizes subcorneal hemorrhages, revealing red, blue, black homogeneous pattern or red, black globules at the periphery of the lesion. Sometime when the dermoscopy is not contributory, we have to go for a skin biopsy to rule out melanoma. Management condition is asymptomatic. Important lies in its resemblance to acral malignant melanoma. When in doubt, careful paring away of stratum corneum is generally sufficient to remove the pigmentation. This is a very interesting heading, that is skin reaction to the musical instruments. These are the skin surface changes that may occur following the repetitive movements made by musicians required in instrument practice, although contact allergy should not be overlooked. Differences in presentation depends upon the type of instrument and body site involved. Clinical appearance of most skin reactions to musical instruments is callosities, lichen simplex chronicus type of reaction, irritant contact dermatitis with repeated friction or pressure at the site of contact and as an exacerbating factor. The predisposing factors include faulty techniques, sweating, and excessive hours of playing, so it is common in the early learners. Patient presents with lichenification, hyperpigmentation, redness, swelling, papules, pustules, occasionally cysts, depending upon the instrument and body site. Trauma of the fingers can also damage the nail and its associated tissues. Contact allergy in musicians are usually to the rosin, string instruments, exotic woods, string instruments, woodwind instruments, chin rests, nickel, as in flute and brass instruments, cane reeds, seen in saxophone or the clarinet, and the propolis, the violin varnish. Violin and viola players develop fiddler's neck, characterized by localized plaques of lichenification, often with hyperpigmentation, redness, and inflammatory papules, pustules, and cysts. Violinists are subject to developing thickened pads over the interphalangeal joints, which are known as the garrod pads or fiddler's fingers. Thrombosis of axillary and subclavian vein have also developed due to viola. Then the pizzicato paronychia is another hazard of the string players. Then finger callosities on the pulp of the fingers occur in many musical instrument pairs, and typical example is the harpist finger. Piano paronychia is associated with long hours of piano playing, and nails are loosened by repetitive glissando, which is the gliding of fingers over the keys. Guitar nipple is found in young girls present with inflamed cystic swellings at the base of the nipple. Then the cylists can develop a condition known as the cylists chest from pressure producing redness, edema, and pigmentation over the sternal area. Cyst knee and even scleroscrotum is described. Then clarinist cheilitis, eczematous condition of the middle portion of the lower lip under the reed of the clarinet. The flutist chin is probably similar to the fiddler chin is because of resting of the flute on the labiomental crease resulting in lichenification. The drummer digit is erosion or blister on the left ring finger. The black dermographism of the lip is described in flute player using a lotion containing zinc oxide, titanium dioxide, and iron oxide and talc. The wind instruments player can develop permanent laxity of the cheek due to forceful blowing of the trumpet because of the rupture of orbicularis oculi, oris, and this is called as the Sat-Shumo syndrome. Management. Periods of refraining from playing is recommended if possible. Patch testing is required to identify potential allergens. In many cases, modification of techniques may all that is required, which resolves the skin reaction in musicians. For more recalcitrant cases, particularly in irritant or allergic contact dermatitis, topical corticosteroid or topical calcineurin inhibitors may be used. In cases of allergic contact dermatitis, substitution of allergic components of instruments may be possible. Callosities are reduced by use of emollients, keratolytics, and mild abrasion with the pumice stone. Another condition I'm going to discuss is the hypothenar-Hammer syndrome. Hypothenar-Hammer syndrome is an ischemic neurological changes in digits in the distribution of ulnar artery following repetitive trauma. It's typically associated with actions that use the hand to hammer, push, or squeeze. The syndrome is found mainly among the individuals in certain crafts and occupations like mechanics and carpenters, but also due to sporting injury like golf and badminton. Conditions tend to present in mid-40s. Among the manual workers, most patients are male. Pathogenesis. The proposed pathogenesis is superficial palmar branch of ulnar artery. Ulnar artery is compressed against the hook of hamate that can lead to stenosis, occlusion, or aneurysm, and thrombosis or emboli ensuing. The condition typically presents unilaterally, no association with peripheral vascular disease, hypertension, diabetes, or hyperlipidemia. The proposed pathogenesis is that the superficial there's no association with peripheral vascular disease, hypertension, diabetes, or hyperlipidemia. Clinical features. Patients with this syndrome present with pain or paresthesias with variable degree of ischemic changes, which includes the blackened or scar formation at the ends of second, third, fourth, and fifth digits of the dominant hand. There may be surrounding hyperkeratotic changes. Fingers affected by the underlying vascular pathology are cooler than normal. Some patients have comorbidity factors such as smoking and cold exposure. Investigations should include arteriography, Doppler ultrasound, or CT, which can demonstrate stenosis, occlusion, aneurysms, etc., and provide essential information for vascular surgical repair. MRI is highly informative and minimally invasive method of evaluation. The Allen test to demonstrate signs of chronic ischemia. The ulnar and radial artery are both compressed, while fist is repeatedly. Ulnar and radial artery are both compressed, while fist is repeatedly clenched and relaxed to drain the blood from the hand. And the rate of reperfusion of the hand is observed. This is repeated, so both the ulnar and radial artery are tested. A negative test indicates poor perfusion from that vessel, and this serves as a quick clinical assessment. Management, it includes counseling to avoid the repeated trauma, minimize exposure to cold, and stop smoking. Second line is aspirin and calcium channel blockers. Third line is vascular surgical repair, generally required for thrombolytic measures or restore the abnormal vasculature and appropriate reconstruction. Ashen-back syndrome. It's a sudden, painful, bluish discoloration and swelling of a finger or fingers, sometimes on palms of the hands or sometimes the palm of the hands, often after a physical effort of gripping or twisting. Female preponderance is reported. Raynaud's may be associated, and it is caused by rupture of a small vein. Patient may present with sharp pain in hand, particularly the volar aspect of the finger, accompanied by rapid bluish discoloration of the affected digit. This occurs after minor trauma or light manual work and may be recurrent and force the patient to withdraw from work involving the manual tasks. Its importance is that it may be confused with Raynaud's phenomena. The condition is self-limiting and resolved within a few days. Spectacle frame acanthoma. This condition is a skin change due to contact with spectacle frame. Spectacle frame acanthoma is characterized by localized skin thickening in response to low-grade chronic pressure from the spectacle frames. It's often unilateral, occur post-auricular groove or on the bridge of the nose, and is commonly mistaken for basal cell carcinoma in predisposed individuals. In review of 27 published cases, there is male predominance. Friction between the skin and spectacle frame at the post-auricular fold or the lateral nose lead to localized epidermal hyperplasia. Predisposing factors are weight of the spectacle, minor derangement in the local anatomy, and maceration. Histology show acanthosis and hyperkeratosis of the epidermis. Typical lesions occur behind the ear or on the side of the nose as soft flesh-colored papules, as you can see the papule here, and nodule or plaque, often with a groove at the side where there's contact with the spectacle frame. Management. It usually resolves after a few weeks or months if wearing of that typical spectacle is discontinued. A thin hydrocolloidal silicone dressing is applied to overlying skin as a cushion. Second line is corticosteroids injected intralesionally. Third line is condition may be treated by surgical excision, electrosurgery, or curettage. Semicircular lipoatrophy is caused by mechanical injury to the subcutaneous fat, especially on the lower leg, often followed by atrophic changes inducing band-like depression in the skin. Mainly occur in women between 20 to 40 years, usually correspond to pressure from the edge of the desk while working and pressure from the folds in the trousers. The semicircular lipoatrophy on thigh can also occur following a therapeutic injections. Clinical features. Semicircular lipoatrophy is characterized by one or more partial horizontal band-like depression, usually on the anterolateral thigh. Management. When cause is identified, it should be removed. A spontaneous resolution occur in most cases after 9 months to 4 years. Acne mechanica is a localized form of acneiform eruption induced by occlusion or friction. Most cases in literature refer to patients who are using medical devices such as prosthetics, crutches, or athletes who are experiencing friction from the use of equipment and protective clothing. Friction with heat, increased humidity, maceration may cause acneiform folliculitis. The effect of occlusion has been proposed to lead to rupture of microcomedones that are not ordinarily visible clinically. Clinical features. Right-handed students may have predominant left-handed facial acne from pressure of the left hand. High neck jersey, shoulder pads, seat backs, in trucks, or even adhesive plasters produce sufficient mechanical stress to lead to acne mechanica. It is also described in young patients lying in hospital bed for several weeks and on face following jaw splinting with the use of orthopedic crutches. The resultant acne can be severe. For example, acne conglobata occurring on the buttocks in transatlantic rovers. Management. Devices in contact with skin should be removed as soon as possible if they are not in use. For example, sport equipment should be removed immediately after the activity is over. Benzyl peroxide is applied for 5 minutes, used to clean the skin prior to being rinsed off. Topical retinoids applied at night, other keratolytics like 3% salicylic acid and 8% resorcinol in 70% ethanol is useful. Dermatoses due to the traumatic effect of sports. This is also a very important subject. Skin conditions related to sports include the mechanical injuries and other direct consequences of the sporting activity. Some of the clinical entities are highly characteristic. Skin adapts to training, developing a higher degree of adaptivity, but requires time and continuity in the chosen sport. Many traumatic effects occur in the weekend joggers or the summer holiday activist. So those who are pursuing the sports activity very irregularly. Wheelchair athletes is particularly prone to blisters and pressure injuries. Some of the dermatoses affecting those engaged in sports are the indirect consequence of trauma. These include infections such as viral wart, impetigo, frunculosis, herpes simplex, molluscum, and tinea corporis. Sport of mud wrestlers is associated with gram-negative folliculitis. Tinea pedis is often a mixed infection with gram-negative bacteria, common in swimming pools. Otitis externa is also one of the common swimming pool problem. Trauma together with heat and moisture are likely contributing factors to contact dermatitis during various sporting activities. Sports enthusiasts often significant risk of sunburn, skin cancer, cold injury. In hot climates, miliaria and hyperhidrosis. Sporting activities can exacerbate pre-existing skin disease like atopic dermatitis, psoriasis, and acne. A spectrum of sport-related skin disorders include anabolic steroid misuse, physical urticarias, exercise-induced anaphylaxis, and leukocytoclastic vasculitis. Clinical features: blisters as a result of violent or unaccustomed localized friction, most common on weight-bearing surfaces and in wheelchair athletes, including the back. Heat and humidity favor the development of blisters. Black heel, already described, common after sports where there is sudden stops and jumps like baseball, also in the badminton. Similar condition of black palm occur in weightlifters, golfers, and tennis players. Petechiae around the knee in long distant runners. Annular purpura occur in skin stuck by tennis ball, which is known as a ping pong patch. Annular purpura of different type is described in association with step aerobics, where annular purpura lesion develop on the legs. Subungual hematoma present as redness, edema, and thrombing pain among the racket sports enthusiasts like tennis toe, joggers toe, splinter hemorrhages seen in golfers. Tennis toe most often affect the first and second toe, whichever is the longer, and symptoms and signs may mimic a fracture. Jogger toe involve the third, fourth, and fifth toe. So tennis toe, first and second toe, jogger toe, third, fourth, and fifth toe. Hyperpigmentation resulting from a small ecchymosis in the skin on sides and upper portion of the gluteal cleft. Distinctive finding in long-distance runner is called as the runner's rump, and it's caused by contact between the buttocks while running. Annular hematoma affect the athletes in close contact, for example, wrestlers, boxing, and judo. Auricular hematoma, that is hematoma on the ear. It is caused by shearing forces separating the perichondrium and cartilage, leading to accumulation of blood in serum. Abrasions are common in many sports, but particularly the wrestlers on mats and artificial troughs also produce trough toes. Abrasion from skateboards are also common. Acute inflammation is the turf toe, a painful condition where there is edema and redness on the dorsal aspect of great toe with acute tendonitis of the flexion and extensor tendons, frequently athletes playing on the artificial trough. Jogger's nipple, found in women who run without braziers, but also in men who wear shirts containing coarse fibers. It may be more prevalent when ambient conditions are cool, making nipples erect, when the skin is moist from sweating, and increase the frictional resistance. Similar condition is seen in competitive cyclists, but suggested that injury is thermal rather than friction. Corns and calluses. Many sport activity result in calluses. Some examples are pulling both hands in the rowers. When calluses or corns are a problem on the feet in runners, it's important to consider the basic biomechanical principles of the foot, which may require some specialist orthopedic intervention. Athlete's nodule. Entity known as the surfer nodule or the athlete nodule present on anterior tibialar prominence, dorsa of feet or knuckles. Similar nodules develop over the sacrococcygeal area of Japanese students attributed to pressure from the bicycle saddle. These asymptomatic nodules show dermal fibrosis as well as epidermal hyperplasia. Knuckle pads occur on sides, but these fail to resolve when athletic activities is discontinued. Acne mechanica is already described, and many precede acne keloidalis nuchae. Swimmer's shoulders. Transient red plaques caused by friction from unshaven face during the freestyle swimming. Intertrigo of groin is a problem in heavily muscled athletes. Judos, joggers, which occur in jogging following vigorous, occurring while jogging following vigorous judo. Mogul skier's palm, consisting of hypothenar eminence from repetitive planting of ski poles. Hooking thumb, unique and competitive weightlifters consist of abrasions, hematoma, and callus on the distal third of the thumb. Striae distensi described in weightlifters. Area involved are anterior shoulder, lower back, and thigh. Painful pysogenic pedal papules and muscle herniatures. Then bicyclist vulva, unilateral lymphedema resulting for repetitive chafing and folliculitis. Now the topic is foreign body reactions. This is a host of immune responses, typically granulomatous to exogenous material within the skin. This is usually as a result of deep penetrating injuries to the skin by material itself during surgery or by injection. Epidermis, hair, and nail can induce a foreign body reaction if implanted in or beneath the dermis. Some extraneous material like silicon and zirconium incite a characteristic pattern of foreign body granuloma. Pathophysiology, the biological response to foreign body, will depend upon its composition, how it enters the body site where it enters, the quantity of material, and its physical forms. Some reactions are complicated by infection, especially traumatic inoculation of wood splinters or vegetation spines, which can induce porotrichosis, deep mycotic infections, or some pyogenic infections. When material has penetrated the skin, there is usually a phase of acute inflammation in response to injury, and persistent foreign material results in accumulation of macrophages, epithelioid histocytes, and giant cells, which is Langerhans as well as foreign body, and ultimately forming a foreign body granule. Histopathologically, it looks like sarcoidosis, unless the foreign material is identified by polarized microscopy. Pathology. The classic histopathology of foreign body reaction consists of foreign body granuloma containing multinucleated giant cells with haphazardly arranged nuclei interspersed with neutrophils and necrotic debris. Granuloma may contain foreign bodies such as suture material, talc, tattoo hair. Polarized light microscopy and special stains are considered when foreign body reactions are suspected. So the foreign material causing sarcoidal granuloma may include silica or glass, tattoo pigmentation, zirconium seen in deodorant and cosmetics, beryllium, zinc, acrylic or nylon fibers, keratin, rarely instead of foreign body type, exogenous ochronosis, and many others. So this is a sarcoidal reaction in tattoo. You can see the tattoo pig ink and the sarcoidal granulomas, which are very well demarcated cell-poor granulomas. Clinical presentation depends on mode of entry and nature of foreign body and associated infections. Retained foreign bodies are commonly associated with bacterial infections, which are resistant to antibiotic therapy. Vegetative foreign bodies are associated with fungal infections. Soft tissue infections manifest as cellulitis, abscess, or draining sinus. A wound that failed to heal or continues to cause pain with movement may suggest a presence of foreign body, as can the persistence of purulent discharge. Many types of foreign body reactions are seen clinically as reddish brown or purple papules, nodules, or plaques. The lesions often become harder over time because of fibrosis. Some material result in discharge even when there is no infection. For example, paraffins and other oils. The implanted material may produce pigmentary changes like carbon and metal, resulting in tattoo-like blackish or bluish black color. it's important to recognize that even a small external sign of entry of a foreign body can denote significant damage to the deeper structures, such as tendon, joint, or bone. This is especially true of the high pressure injections like grease, paint, water, and some firearm injuries. Patient with foreign body implanted into the skin may have discomfort at the wound site. Palpation of mass may justify extending the wound to explore it adequately and removing the foreign material. Investigations used are plain radiograph, often detect foreign body, but visualization depends on the object density, configuration, size, and orientation. Metals, bone, teeth, pencil, graphite, some plastics, glass, and gravel are radio-opaque, but may not be visible if located over a radiologically dense background such as bone. But other backgrounds, they are quite visible. Some materials that are less dense than tissue are seen as filling defects, like white pine. Ultrasonography, often helpful for vegetative foreign bodies that are not visible on X-rays. CT scanning can visualize the wooden material, produce images in multiple planes which can aid localization and can relate foreign body accurately. MRI is comparable to CT scan for material of similar density to soft tissue and superior for detection of plastics. Gravel produce several artifacts. Histopathology. Presence of particulate material in phagocytic cells can often be seen in H&E stained sections. PS stain often show splinters, talcs, starch, and fungi. Dark field illumination helps visualize some metallic material. Polarized microscopy demonstrates silica, talc, suture material, wood, and plant material. Element present can be ascertained by electron dispersive X-ray analysis known as EDXA and lower molecular weight substances electron energy loss spectroscopy EELS. Management. First, it is difficult to judge whether or not to remove a foreign body. Reactive material, especially the organic nature, thorn and spines, should be removed so as to prevent the infection. Non-reactivity, small size, inaccessibility may weigh in favor of leaving a foreign body. All wounds should be clean and tetanus immunization is provided if necessary. After removal, wounds should be irrigated and debrided if necessary. Indications of removal of foreign body. Heavy bacterial contamination like teeth and soil. Toxicity. Spines with venom and heavy metal. Proximity to tendon, vessels, nerves, and fractured bones. Then impairment of mechanical functions like abnormal gait in foreign body in the foot, intra-articular location, potential for migration, intravascular location, persistent pain, established infection or inflammation, allergic reaction, cosmetic or psychological considerations. Paraphenomas. Some vegetable oil containing triglycerides can be digested by lipases, but others and mineral oil, grease, and wax cannot be broken down and elicit a foreign body reaction. Most instances of paraphenoma nowadays are caused by misguided attempt at tissue augmentation, often self-administered. Penis is most common site. Other sites include male breast, gluteal region, and extremities. Pathology of paraphenoma show round clear spaces of varying sizes surrounded by fibrous tissue and mixed inflammatory reaction, including foamy macrophages, multinucleated giant cells, and Swiss cheese appearance. A study of paraphenomas of male breast reported MRI appearance that can be reliably distinguish a mass caused by paraffin injection from a breast cancer. Treatment is by excision, require a local or distant flap reconstruction as well. Sclerodermiform reaction to vitamin K and vitamin B12 injections. An intramuscular injection of vitamin K is followed by red plaque in lumbosacral area, which takes a dusky color, becomes infiltrated and itchy in 10 to 15 days. After some months, it resembles a patch of scleroderma, ivory white in color with surrounding lilac ring. Similar changes are seen in upper arm after intramuscular injection of vitamin K. Histopathology demonstrates dermal and panicular sclerosis. There is tendency to resolve slowly following withdrawal of vitamin K injections. Localized sclerodermoid reaction is also reported at sites of intramuscular injection of vitamin B12. Pentazocine ulcers, distinctive, woody induration with overlying ulceration, is characteristic of repeated intramuscular or subcutaneous use of analgesic pentazocine. Such reactions are usually found in narcotic abusers. Long-standing changes occurring around major joint can lead to myofibrosis and contractures. Reactions to silicone. Silicone is used medically in three forms: liquid or soft tissue augmentation, bag gel implants for augmentation mammoplasty, solid elastomers in joint prosthesis. In tissue, it has tendency to migrate both locally and via lymphatics. Even medical grade silicone can produce granulomatous reaction. When silicone bag gel material ruptures, it migrates along the facial plane and gravitates into the skin, producing indurated inflammatory subcutaneous masses. Histological appearance is of varying size vacuoles similar to paraphenomas, but less fibrosis and usually absence of granulomatous response. A case is reported of widespread granulomatous papules developing many years after liquid silicone injection into the face. It is suggested that granulomatous response to silicone occurring as a manifestation of sarcoidosis. If adult trends are present, a more inflammatory reaction is described. The silicone reactions can be treated with surgery. Amelioration of inflammatory response by treatment with minocycline is reported. The fiberglass dermatitis. Reaction to glass fiber caused by physical injury, although allergic dermatitis resulting from residual epoxy resin in fiber is described. The fiber that causes this reaction must be greater than 4 micrometer in diameter. As a symptom, pruritus is common and occur with or without skin lesion, and the lesion consists of red transient papules, often follicular. Forearm, hand, face, neck, and flexural folds are common sites. Covered sites can be affected because the fibers can penetrate clothing. Glass fibers are difficult to see in biopsy specimen but can be recovered by scotch tape stripping. Complication of tattoos. Tattoo is a very commonly done procedure. It is a deliberate introduction of permanent colors into the skin through punctures and for accidental entry of pigment material. The latter is common after abrasion injury, for instance in cyclists and coal miners. Also from gunpowder used in replica firearms. Tattooing can occur from contact with jewelry, for example earrings. Placement of tattoo for cosmetic reason has increased in the recent years. For body art, most common method of tattoo use an electric tattoo machine in which group of oscillating needles inject ink into the skin with 80 to 150 times a second frequency. Since tattoo instruments come in contact with blood, infectious diseases can be transmitted if appropriate precautions are ignored. The potential infection risk has led to prohibition of blood donation for 12 months in patients receiving tattoos in USA. Modern tattooing ink are carbon-based pigment. Many of the brighter tattoo pigment are derived from ABS particles less than 1 micrometer in diameter. The traditional pigment which is used in tattoo are the indigo, caramine, vermilion, India ink, chrome green, cobalt blue, cinnabar, cadmium sulfide. Ferrous oxide is used to pigment the eyebrow area. Spectrometry analysis have shown most commonly identified elements are aluminium, oxygen, titanium, and carbon. Immediate after tattooing, there is local traumatic response with formation of a scab. Although pyogenic infection as a post-procedure complication is uncommon, MRSA, molluscum contagiosum, viral wart, hepatitis B and C virus, and HIV or syphilis may be transmitted. Aside from infectious complications, induction of skin diseases by Koebner phenomena such as psoriasis, lichen planus, vitiligo, Darius, and DLE may develop. Sarcoidal granulomatous inflammation may also develop in tattoo after a long time. Abnormal photosensitivity in tattoo is described with cadmium yellow tattoos. Perforating granuloma annular is also complicated tattoo, and treatment of decorative tattoo is discussed in my talk on lasers, which you can consult in my channel. Hair as a foreign body. Fragment of hair may penetrate the skin and cause variety of reaction according to the site, depth of penetration, ranging from small redness to formation of abscess or sinus. Chronic reaction take the form of foreign body granulomas, which may present as subcutaneous nodules. The first is the barber hair sinus. Interdigital sinuses are common in men barbers, presumably because of the short, sharp hair fragments generated from cutting the men hair. Lesions are tender nodules within the affected finger web, containing a central sinus that may intermittently discharge. Hair also cause inflammation when implanted into finger pulp beneath the fingernail. Hair sinus on the feet. Hair fragment may penetrate skin of the feet. Long curved hair embed on the toes and ankle are recorded in ladies' hairdressers. Deep penetration provoke tender nodule or abscess and surgical excision is necessary. Creeping hair. Loose individual hair can penetrate skin and migrate superficially, producing the wave-like linear called creeping hair and clinically resembles cutaneous larva migrans. Hair can be easily removed by extraction it through the shallow incision. Milker sinus is uncommon but disabling. Fragment of cow hair may penetrate deeply, involving even the tendon sheet. Secondary infection often follows, sometimes by dermatophytes. Most lesions involve second and third web of right hand, forming tender nodule and discharging sinus. A spontaneous cure may eventually take place, but may be longer delayed. Surgical intervention is advisable. Anogenital pilonidal sinus. The sinus itself does not have hair follicle. Penetrating hair cause a foreign body giant cell reaction, sometimes with secondary bacterial infection, and cause sudden onset of pilonidal abscess. In addition to the primary tract resulting from the initiating hair, there may be secondary tracts opening into the cavity. Presentation is usually a midline opening or series of openings in the natal cleft about 5 cm from the anus. Males are affected much more commonly than female, with peak incidence of 15 to 24. It occurs most commonly in individuals with dark, stiff hairs. Examination revealed characteristic opening at the natal cleft with tuft of hair seen emerging. Management. A small sinus is sometimes treated by removal of hair, regular shaving of surrounding skin, phenol injection technique, or curettage. Most patients are treated either by excision or primary closure or by laying open and healing by secondary intention or repair with skin flaps. Squamous cell carcinoma is described as a rare complication of pilonidal sinus. Hair thread tunicus syndrome. Foreign body reaction to hair and hair-like fibers describe falling encirclement of finger, toes, and penis, usually as an accidental event, but also an instance of child abuse. Affected area present as dusky swelling, sometimes with focal discharge, and hair may be completely buried and only evident after exploration. Pseudofolliculitis barbae. Foreign body reaction to ingrown obliquely cut hair, seen in curly hairs, and causes an eruption of red papules in the bearded area. The pubic hair has also been involved. treatment is generally unsatisfactory. And systemic remedies include topical retinoids, alpha hydroxy acid, and antibiotics. Depilation techniques modify the physical triggers in pseudofolliculitis Barbie, and laser hair removal with alexandrite or anti-yag laser may offer the best approach thus far. Hand-arm vibration syndrome. Transmission of vibration energy to the skin is associated with a number of chronic biological consequences, best defined under hand-arm vibration syndrome. The term vibration white fingers is no longer used, has been long used for Raynaud's phenomena resulting from use of the handheld vibratory tools. The most common tools caused by hand-arm vibration syndrome are the percussive metalworking machine, such as riveting and fettling tools, drills, impact wrenches, jackhammers, road breaking tools, and the chainsaw. It's also recognized that vibration can induce localized hyperhidrosis, callus formation, vibratory angioedema, and a condition characterized by pain, swelling, and erythrocyanosis. Low ambient temperature, firm gripping of the equipment, and smoking are risk factor. Existing vascular disease and vasoconstrictive medications may be a risk factor. Structural neural changes noted include loss of myelin, increased number of Schwann cells, and fibrosis. Vascular lumina are ruptured, probably by both internal thickening and smooth muscle hypertrophy. An in vivo study demonstrated decreased vasodilation response in finger of patient with hand-arm vibration syndrome when challenged with histamine and endothelin 1. A generalized abnormality in autonomic nervous system may cause orthostatic hypotension and vasoconstriction of the limbs, not directly exposed to vibration. Clinical features. There are three possible. Major complication of hand-arm vibration syndrome: circulatory, neural, and musculoskeletal. A highly variable latent period. Initial symptoms are usually of tingling and numbness of one finger, followed by episodes of blanching, initially of the tip of the fingers with progression towards the base. Attack lasts for 10 to 15 minutes, followed by painful reactive hyperemia. With progression of the disease, there is reduction in touch sensation and difficulty in doing fine manual work. Muscle fatigue and weakness are common, probably of incomplete muscular contraction. Late in the disease, attacks of pallor wane, but there is persistent dusky cyanosis, swelling, and stiffness of digits. Classification of severity. Patient with HAVS should be staged as a part of assessment of disability. For each hand separately, Stockholm workshop scales are most widely used. The clinical variant. Vibratory angioedema tend to occur at low frequencies, approximately 10 Hz, and produced by handling a power lawn mower or by rubbing or toweling the skin. The condition may be quite common among mountain bikers. Diagnosis is based on history of vibration exposure. For purpose of assessing, following tests are regarded necessary: finger systolic blood pressure, following cooling to assess vascular abnormality, either vibrometry or asthenometry for neurological dysfunctions, and grip strength. Laser Doppler flowmetry is used to assess skin blood flow. Management. Because of more advanced stages of HAVS are irreversible, preventive measures and surveillance of at-risk workers are widely regarded as essential. Much effort is made to redesign equipment so reduce vibration. Workers should be informed of hazards of the occupation and should wear warm anti-vibratory gloves, avoid smoking, and undergo regular medical surveillance. It is best for those at risk to avoid medications that can cause vasoconstriction, like beta blockers. First line is important to maintain central body temperature and avoid allowing the hands to become cool. Mittens are preferable than gloves. Smoking is strongly discouraged. Calcium channel antagonists like nifedipine relieve the vascular symptoms. Other drugs include alpha adrenocorticoid receptors antagonists such as thymoxamine and some prostanoids. Case report is indicated positive response to iloprost infusion in patient with severe sympathectomy is not generally effective. First line, it is important to maintain effective. Last topic, pysogenic pedal papule. They are soft skin-colored papules and nodules that appear on side of heels, usually on medial aspect when subject stands, and disappear when the weight is taken off from the foot. They are common, painless, indeed often unnoticed, increased frequency in certain diseases like Ehlers-Danlos. Painless papule consists of normal fat herniation, but when pain occurs, it is attributed to herniation of fat into the dermis with resultant reduction in dermal thickness. Similar papules are noticed on the lateral edge of hand and wrist, and as known as the pysogenic Palmer papules. Ultrasound demonstrate globules protruding into the dermis. First line management is painful involvement of symptoms, improvement of symptoms sometimes achieved by avoidance of prolonged standing and when relevant loss of weight. Second line compression hosiery, electro aquapuncture, injection of equal parts of betamethasone and bupivacaine, supportive rubber foot pads and heel cusps. Third line, if conservative measure fail, small excision of papules can be curative. This brings me to end of my talk. Although this talk was quite long, I am sorry for that, but I had to complete it in one lecture. I hope this lecture was of benefit to you. So thank you very much. Goodbye and have a good day. See you next time with another edition of my talk.